Good afternoon, everyone, and welcome to the University Honors College. My name is Dr. Philip Phillips, and I'm the Associate Dean. I'm pleased to welcome all of my students here today, and also anyone who may be watching this on YouTube. Our series this semester is devoted to global engagement, and as I told you at our very first class meeting, we're going to start the semester with two keynote presentations. The first of which is by Tara McKay. Tara McKay is Assistant Professor of Medicine, Health, and Society, affiliated faculty in the Sociology Department, and affiliated faculty in the Department of Health Policy at Vanderbilt University. She received her BA in Psychology from Occidental College and her MA and PhD in Sociology from UCLA. Before joining the Center for Medicine, Health, and Society at Vanderbilt, Dr. McKay was Robert Wood Johnson Foundation Scholar in Health Policy Research at the University of California, Berkeley, and the University of California, San Francisco. Her research and teaching interests include medical sociology, gender, sexualities, global health, and health policy. Her research has been funded by the National Science Foundation, the National Institutes of Health, and the American Council for Learned Societies, among others. Her keynote presentation today is entitled Pursuing Social Justice Through Global Health Research and Science. Please join me in welcoming Dr. McKay.
Thank you, Dr. Phillips. Get started. Thank you all for having me today. I'm really excited to present some of this to you and hopefully get us thinking and talking more about how to move equity and rights through global health. It's something that I'm passionate about. It's something that I think a lot of people come to global health looking for and are drawn to global health because they want to be working on some of these issues. And so we're going to talk a little bit about some of the challenges to making that happen and thinking hopefully critically about how we can actually engage in some of this work in ways that move forward our goals, right? That aren't just reproducing some of the global inequalities that have been there for a long time that, our countries that we have come from might have participated in, right? So we're working here. I want us to think a little bit about in particular, how our understandings of disease actually affect how we respond to diseases in global health, and actually how we can make those responses a little more equitable, right? Through our own actions, our own critical reflection on what's going on in global health. So I've got some images here to kind of set the stage. My expertise is in HIV and LGBT health. So these are areas that I've worked in for the last 10 years and thought a lot about. So a lot of my examples today will be about HIV or LGBT health related. But we can also think about maybe what you're looking at on the right is the BMI scale for obesity, right? And thinking about cutoffs for where people are indicated as healthy versus unhealthy, right? And how these are also perhaps subject to some kinds of understandings and ideas about disease, who has it, who's responsible for it in terms of our health or unhealth, and how we address it, right? One thing you might also notice about this kind of cutoff, these cutoffs that are used for BMI is they tend to be on a scale of 5, right? So we have cutoffs at 25, at 30, at 35 for indicating different levels of poor health, right? And so I'm going to show you an example of what happens when we actually change the definitions of what's healthy and unhealthy. And that also happens with these examples on the left. So on the left, you have a newspaper article clipping from the 1982 about new cases of what came to be called HIV and AIDS in a homosexual population in the US. Well, that kind of really trained our thinking that we didn't see this so much in women in the US. And so there's a movement in the early 1990s that actually gets women's issues around HIV and AIDS seen. And this is another definitional change that makes an important kind of impact here. So these are our guiding questions for today, thinking about our ideas and understandings of disease, how they affect our responses, how we can actually critically engage with some of those understandings to do a better job in creating equity and equality in global health. So I like to give you kind of 3 things to guide our understanding of what's going on today. 3 things I'm going to try and convince you of, 3 things that will help you remember what we did today so that, a week from now, a month from now, if you remember anything, maybe it's one of these 3 things, okay? The first is something that comes out of sociology of knowledge. I myself am a sociologist, and so I like to think a lot about where knowledge comes from, why we think the things that we do, why we think we know things that we do, and this is a very kind of strong current in sociology. And so what I will argue or show you, demonstrate to you, is that the production of scientific information is still a part of this. It's embedded in social relationships. It is socially produced. For those of you who are maybe coming at this from a bio or a chem kind of focus in terms of thinking about scientific information, we go through that scientific method. We're taught a lot about the objectivity of scientific information. Well, I'm here to kind of push on that, show you a different view of information and how it gets produced, and hopefully challenge some of that in thinking. Second is that some of the relationships that we use to actually produce information are more unequal than others and actually challenge us to think about what's really meant when we talk about global health. Is it really global? Is it really encompassing the world in the way that we expect it to, or is it kind of also reproducing some of these power struggles within our social relationships and our social world already? And then third is directly about engaging in this work and getting involved. And I think a lot of us come to this work because we have this passion for addressing social inequalities. But if we do this uncritically, it actually can help reproduce some of these inequalities that we actually want to address, right? So I have just a few kind of thoughts for you on how to engage more critically in some of the work that you might end up doing in disaster relief, for example, in global health, in research, and so on. So let's go back to that first thing, the production of scientific information being embedded in social relationships, all right? So the first thing that I think we can show this, that I can most easily show this to you in is thinking about definitions, right? So what we know about disease, what we actually know, is strongly informed by the ways that we define disease, okay? And importantly, sociology and medical sociology, sociology of knowledge, has tried to push on these definitions a lot. How do we know what we know? What are these definitions actually kind of putting out there? And they've thought a lot about how some of these definitions are not neutral, right? They actually reflect social power dynamics, economic power dynamics, and so on in our everyday lives. They may even reproduce some of those inequalities and can promote certain kinds of understandings and solutions to a problem that may or may not benefit everyone equally, right? So let me give you a couple of examples related to that. And I'm going to tell you a story related to this issue of women and HIV. So in the early 1980s, we have new cases of what comes to be called HIV, right, and AIDS. And most of the cases are diagnosed in gay men, right? All along, there are a few cases here and there that are among women, and certainly this demographic that's affected by HIV grows over the 1980s. But the guidelines for diagnosing, the definition of AIDS, right? The guidelines for diagnosing HIV and AIDS actually didn't include a lot of illnesses that women might get that were related to HIV. So when you have HIV, it compromises your immune system and you get other opportunistic infections, right? Tuberculosis is a common one, but other kinds of cancers show up too. And when the CDC set the guidelines, the definition for HIV, they didn't include certain cancers that women get quite a lot, like cervical cancer, for example. And so this was something that showed up a lot when women would actually be diagnosed with HIV or AIDS, is they'd have these cervical cancers. And so during, from 1989 to 1992, the AIDS Coalition in the United States, as well as the Minority Women's Action Committee, organized to actually try and get the CDC to change the definition of illnesses that would diagnose you with HIV or AIDS. And they protested at the CDC. You can see this news footage, essentially that women were dying of AIDS, but they weren't actually being diagnosed with it, right? So what did they do? What happened? In 1993, the CDC actually adjusted its definition. They included cervical cancers and some other women's specific illnesses to the clinical definition of AIDS. And immediately, right, we actually see a big change in the number of people who are diagnosed with HIV. And the reports from the CDC and the Office of AIDS in the government estimated that this change actually increased the number of women living with AIDS by 61% at that time, right? There are some other definitional changes happening at the same time, but essentially those graphs where you, on the right-hand side, the white bars are the effect of that change in definition, right? If we hadn't changed the definition, what would have happened? Well, cases were starting to decline among gay men at this time, but it was moving into other demographic groups. And if we hadn't changed that definition at that time, we wouldn't have actually seen those cases and diagnosed those cases. Here's another example using that BMI measure, right? Most of you are familiar with the body mass index that we use to measure kind of healthfulness in people's weight. Well, it wasn't actually set at the same criteria that it is now, right? It hasn't always been that way. So at a certain time in 1998, we actually changed where that cutoff was in terms of who was healthy and who was fat or obese, right? And so when they changed this definition overnight, 25 million Americans who weren't fat when they went to bed were fat when they woke up, right? So this is a CNN story on that change in definition when they actually changed the numbers, right? So when you, I think, looking at moments where we've changed a definition, it's actually very easy to see, much easier than, like, say, looking at a static definition that hasn't changed a lot, where it's easy to see how this is actually socially informed, right? What was the kind of purpose for thinking about changing these definitions? Well, you had social movement pressure on the one hand from women's groups who wanted to see HIV clinical definitions change. And in this BMI example, you had other things going on with doctors and policy where they decided that this change was what they wanted to kind of enforce, right? And so you see how these things are social and political. And not necessarily just biologically based kind of objective facts, right? Another way to see this is in thinking about data, right? So I would argue to you that what we know about disease, what we actually think we know, basic information like how much of that disease we have, the prevalence, the incidence, how many new infections we have, who's got it and where it's going, the transmission routes. This is all strongly influenced by where, among whom, and how hard lots of different kinds of people or institutions look for that disease. And I have one example for you, again from HIV, from a woman who did a study on HIV, actually on the data that we collect, not studying risk behaviors and so on, but actually on the process of collecting data in the Southern Caucasus, which is Azerbaijan, Armenia, and Kazakhstan, right? And so she was interested in looking at where people were doing the testing, how that was affecting estimates of HIV prevalence, right? If you focus on urban areas or you focus on rural areas, that's going to change your estimates. If you focus on women seeking prenatal care, we've known for a long time that affects how much HIV you think you have, right? She was also interested in looking at how social and cultural beliefs about different kinds of behaviors, especially stigmatized behaviors like same-sex sex, like injection drug use, like sex work, actually affect data accuracy, right? So what she did was she interviewed HIV testers in clinics. And she was interested in the beliefs and biases that they brought to the testing encounter and how they explained people's behaviors or didn't, right? So there were kind of several testers who would bring up these kinds of cultural stories about who gets HIV, who's at risk, and why, right? This is an area of the world where you have a lot of people coming and migrating from Iran and other Middle Eastern states. You have influence from Russia to the north as well. And so you have kind of different ideas, mostly based on ethnicity, right? About who engages in what kinds of behaviors, but also some gender elements too. And so she found that testers wouldn't actually ask women if they were engaged in sex work, for example. They would make assumptions based on who they were talking to. If this was a Russian person, for example, they said, oh, they ticked the box. This is definitely a sex worker. If this is, somebody of my own ethnicity, they are not, right? They are a nice, wholesome woman like myself. They would also kind of do this for men around same-sex sexual behavior, right? They would not want to ask that question. That's an maybe impolite or improper question in some of the testers' minds, and so they wouldn't ask. They would check a box or not based on assumptions about who they were talking to, but not actually directly ask that question. Well, what happens when you don't ask that question and it doesn't show up in the testing data is the country that we're talking about actually says they don't have a lot of infections among groups like men who have sex with men. That's what some of these acronyms mean, right? So they're able to not make policy around it. They're able to not fund prevention programs around it because it doesn't exist there, because nobody's ever asked. Right? There are similar examples with the injection drug use. So what I like to show you now is that these kinds of stereotypes, biases, cultural stories about who has what disease actually have real consequences, right? And I'll give you an example of funding treatment for HIV and AIDS. So essentially what's going on here is the blue line is showing deaths from HIV in the US, right? And AIDS-related causes, right? So that might include some of those opportunistic infections where somebody's got AIDS but also dies of tuberculosis, for example. What do you see? You see that big decline right around 1995, right? What happened then? We had our first HIV drugs, right? They weren't amazing, they were pretty toxic, but they actually helped a lot of people, right? At least for some time. And so until we got newer drugs in the 2000s, right? So I want you to keep that year in mind, 1995, that's when that big drop happens. And we see in thousands of deaths actually kind of not happening, right? So we're preventing thousands, tens of thousands of deaths just with the introduction of this drug, of these drugs. This is that same idea of a graph, but worldwide, right? What you'll notice here, that red line is doing the same thing. It's deaths due to HIV, AIDS, and related causes, right? Similar timeline, right? What you notice here is that, if you can read where our year is, it's not 1995, it's 2005, right? That you start to see that peak and decline, right? So that's a 10-year gap that we're thinking about in terms of when people in the US kind of stopped dying, or at least slowing down that pace of death, and when that happened in the rest of the world, right? Why do you think that's going on? Why did it take so long for us to get drugs to other countries? This is, this time, mostly African countries, right? Why did it take so long to get those drugs there, right? Our ideas about who people are and disease are really important here. So scientists in the US and in Europe relied heavily on stereotypes about Africans in particular to really make it so we didn't expend those resources, right? There were certainly valuable concerns about infrastructure. How are we going to get people these drugs? There were certainly concerns about money, right? These drugs were expensive and somebody had to pay for them, right? Or negotiate a lower price, and that came a bit later, right? But our own aid agency, USAID, also thought that Africans couldn't tell time, right? that they don't know what watches and clocks are. They don't use Western means for telling time. They use the sun. These drugs have to be administered during a certain sequence of time during the day, right? Every 12 hours or so, 6 hours, 8 hours, right? A regimented time. And so when you say, take it at 10, people will say, what do you mean by 10, right? This is absurd, right? That people can't tell time in other places. But this was our own idea about why we shouldn't send drugs, right? We have no way to get them there. They're expensive, but also they'll just mess everything up, right? In fact, studies have shown since then that some of these populations are much better at adhering to that timetable than our US populations, right? So they were just wrong. But these ideas actually affected who lived and who died, right? You saw that line continue up for 10 years, right? And if you think that was, 17 years ago and not important now, right? I would challenge you to think about how Ebola went, right? This is an excerpt from a piece that was written by the Harvard African Students Association on political action in 2015 during the Ebola epidemic, right? And they were particularly concerned about how the media was representing Ebola, particularly as an African disease, right? Not talking about it as a disease affecting Africa, but as an African disease. And didn't actually portray a lot of the people in Liberia and Sierra Leone and Guinea who were fighting this disease, who were the nurses, who were local health workers, right, who were actually tracing contacts and so on. Instead, the media would show this kind of white savior, this American doctor who showed up and was providing all of the possible care, right? Just a kind of very fictionalized representation of what's going on that doesn't give other people some of that credit, right? And just in case you need a little more encouraging on this idea, I would encourage you to look up the trailer for Outbreak, which is actually a movie about an earlier Ebola-related type fictionalized epidemic, right? That makes its way to some small town in California that came out in 1995, right? It's not HD. It's just not going to be, sorry. It's, a few years too early for that. Watch this trailer, right, on your own time sometime. And then watch the first, 3 minutes of this documentary done by the Discovery Channel, Ebola Inside the Deadly Epidemic, right? Compare them. They are identical in terms of their kind of sensationalizing of different elements of, quote, African cultures, right? This kind of over-attention to monkeys and bushmeat and things people are doing that are just so exotic and strange, right? And really kind of thinking about these African-type diseases, right? So I would encourage you to look those up. It's actually funny. Okay. Okay. So we have these ways that data, that our ideas and understandings and definitions of diseases actually kind of already reflect our social relationships. Well, some of these are more unequal than others, right? And actually have implications for people in terms of what we're actually doing on the ground, right? So I want to talk really quickly about another kind of data, sort of, and that's specimens. Right? So biological specimens, things like blood cells, other tissues, or phlegmy things, gross things, right? Where do they come from? Whose are they? Who gets to actually analyze them, right? And have that intellectual input, right? This is an important question in global health research, right? Whose intellectual agenda is furthered here? Who actually gets the credit? Who actually gets to do some of that work? Who benefits by a lot of the research that we do, right? And what kinds of benefits are those? So for those of you who maybe are less familiar with HIV, there's actually a lot of HIVs, right? There are at least 2 big main strands of HIV, HIV-1 and HIV-2. And within HIV-1, which is the main one kind of circulating, we have actually dozens of subtypes, right? And just like the flu, HIV can recombine to make a new subtype. So this is actually quite interesting, right? And if you look at this map, you'll see that in North America, right, our brown space here, we have kind of mostly all the same virus. But if you go to someplace like West Africa, for example, this is kind of do we have a pointer maybe? Yeah, this circle here, right? There are actually lots of different kinds of strands circulating, that could recombine that are just out there, right? Well, they're also always mutating and combining, so we are getting new ones all the time, and people are discovering new ones all the time. In contrast to our kind of subtype B, which is what we have, right? We actually have like other things going on the sub-Saharan African kind of region where it's actually subtypes C and A that are most predominant, and lots of other different kinds of combinations that are prevalent. But what happened in terms of the last 30 years or so, as we've developed research around HIV? Well, we draw samples from the places where the labs are, and I'll show you a map of that really quick in a second. But you can guess, these mostly reflect populations in the US and Europe. So a lot of what we're researching actually comes from this subtype B, right? And so when we've been developing drugs, when we've been developing all of this vaccine research that's kind of taken off in the last 10 years, what samples do you think they're working on? They're working on samples that are going to be most reflective of populations in North America and Europe, and to some extent South America, Australia, right? And it's not like necessarily that this is intentional, right? This is where the labs are. This is where they find their samples. And in research, for those of you who might be doing any kind of cell line research, right, or who have seen the movie or read the book about Henrietta Lacks, right, it's actually useful to have a cell line to compare to that's consistent, right? If it changes, that becomes harder to compare to because you don't know, is that just a weird change that's different in their cell lines, or is that actually an effect of this treatment I'm adding to the cell line? So if we think about research and the politics of research, we can actually think about how maybe some of that encouraged us to look at a particular strain, right, over time, but how that's left some people kind of out of the loop, right, in terms of maybe what drugs are going to be most effective, right? If all of our drugs have been made to address one subtype, it's feasible, it's possible that some of those drugs don't work as well with other subtypes, right? And we've also focused vaccine research, for example, that's what this map is, on strains that are going to be mostly effective for the global north, right? So if we do get that vaccine, that's the earliest vaccine research that's happened, it's going to be perhaps more effective in areas that have more resources already to deal with the epidemic. And it's only recently that vaccine researchers have added additional subtypes into some of their research. Okay, so after drugs, after vaccines, one of the other kinds of things that science and research bring to developing countries, and that we export quite a lot of, are scientific training and technology. Right? This is one of our key exports, since we actually aren't great at redistributing drugs, right? We do okay. We should be doing better. We're trying to do better. But one of the things we do a lot of is actually bring lab equipment, try and build hospital infrastructure for lab-related tests and things like that, provide jobs, provide training. And these are some of the, I think, best short-term benefits of research that have materialized from a lot of efforts to combat, especially HIV, but also in other areas of global health, right? This image is taken from a little clip that the University of San Francisco put together on some of their efforts, which have basically built this lab at the University of McKay in Uganda, in Kampala, Uganda. And one of the things that they pride themselves on is bringing in people from Uganda to train, to do a lot of this lab work, to pay for some of their education expenses and so on, right? So I don't think these benefits should be thought about uncritically, right? There are still some power struggles here that we can talk about a little bit more. But this is one good example of a short-term benefit of trying to bring other things to that space. Importantly, though, that lab is really an exception, right? So it's identified here on the bottom, Uganda's McKay lab, right? It's one of the only places on the African continent where you can actually do not only collect specimens, but also analyze them and store them, right? And where researchers can have access to them. So what this map is showing you is actually where those other kind of specimens are taken from. That's all of the squares. And there's a sociologist who refers to these places, all of these squares, as blood senders. These are people whose samples we just take and they go somewhere else, right? And you'll notice these circles, which are not very many. There are a few in North America, a few in Europe, and that one in Uganda, where where researchers have access to these data, where you can actually work on some of these samples, or where these samples are sourced from, right? Universities in particular, like MTSU, for example, might source from some of these labs, right? And this is coming from a site that tracks basically where data is coming from clinical trials and stuff on tuberculosis, malaria, neglected tropical diseases, and now Ebola, right? So if we're thinking critically about this, that might be a problem for us. A lot of people are sending their information, they're sending their samples, but they're not actually able to work with them. They're not actually able to think about what the results of some of those studies might be, right? Or engage with that material in a way that's useful to them. In research in particular, local researchers are often kind of limited to that data collection kind of process. They're not engaged on a more intellectual or professional level. So there are some big challenges there in terms of integrating researchers in a more professional way that actually takes advantage of their local knowledge, that takes advantage of their skills and their relationships in a meaningful way. And last, they're not actually encouraged to develop some of their own projects, right? If we're thinking about advancing global health science, we kind of want a lot of different minds on the problem, right? To get to something that is going to be solvable and interesting and actually think about a new problem or an old problem in a new way, right? We need those experiences, but they're often not encouraged because the funds come from here. They come, and the researchers come from here, and they implement a project without a lot of kind of local collaboration in a meaningful way, right? So what can I kind of impart to you in terms of getting involved and thinking about, thinking critically how we can actually redress some of these issues and move forward, right? Some of you may have these experiences as students. And so you'll see like up in the right-hand corner, this is, you may recognize this Onion article head that came around maybe a year or two ago, which is a visit to a rural African village, completely changes women's profile picture, right? But I've put it with some of these other pictures to try and kind of situate that in a broader like context of thinking critically about our actions, right? On the bottom right-hand side, you see basically protest signs from Haiti when the UN came in after the earthquake a few years ago, and some of the UN soldiers brought cholera to the island, right? Which they hadn't had an outbreak of in a while. And so a lot of people died, certainly, but there was a lot of blame shifting as well in terms of who was responsible for this. And so thinking kind of critically about maybe the unintended consequences of some of our good intentions is also one of those things that I would encourage you to be thoughtful about. And then this larger picture in the middle, right? This is an old photo. It's from 1969 from a smallpox vaccination campaign in Niger. And why I like this photo, I like this kind of dynamic with this woman and this kind of unknown vaccinator who's kind of got the new vaccine gun that was kind of novel in this historical moment. And like the kind of confrontational look on her face. But I think it's important for, like, if you're interested in this field, in global science, in global health science, in global health research, in doing this as a practitioner in the future, working in disaster relief, or even, let's say, you're a psychologist and you want to work, in working on PTSD after, like, big major events like earthquakes or something like the cyclones or something like that that actually has a substantial effect on communities. It's important to think about what came before you, right, in terms of global health. So it's built on these pillars of colonial and tropical medicine, And there's a lot of writing on that within critical global health. It's built on some very well-intentioned kind of large mass campaigns from the 50s, 60s, and 70s around mass vaccinations, around kind of otherwise kind of building population health and decreasing fertility and so on, that actually had substantial consequences for some countries, right? We actually promoted forced sterilization in some places. We did all these mass vaccination campaigns that people weren't necessarily informed about, right? And so they have reactions to that. That are valid, that are good to know about, and that we need to be thoughtful about when we go in, because it's also affected how people respond to HIV interventions or Ebola interventions, right? You might have heard of different health workers being chased out of villages or stoned or beaten, right? In some cases even killed in the Ebola response because they had associations with a government that wasn't welcome there, that had hurt some of their people. They also had associations with other Western interventions that weren't necessarily positive, right, in terms of their interpretation or understanding of them. So it's important to understand where global health comes from, what it's come out of. I think it has tried to make a break from these pasts, right? We have a different organizing principle. The people it's drawing are strongly rooted in human rights to health and access to health and providing equitable resources and opportunities for health, right? So that's totally different from earlier iterations. But if we don't think critically about these previous kinds of iterations, we, I think, run the risk of just reproducing them thoughtlessly, right? One of the ways that I've tried to work on this, and this is a hard problem, right? It's hard to see those biases in yourself. It's hard to see that in the work that you do sometimes. One of the ways that I've tried to work on this myself is thinking about whether or not I'm the right person to be doing this work, right? Is there somebody else here who either already knows what I need to know, or, for example, could be trained to do that, right, in a way that actually promotes some local ownership of the project? Is there a reason that they can't be trained to do some of this work or be involved in some of that work? How can I actually get the community that I'm interested in actually more engaged in this question, this problem, solving this issue, and so on, right? So one of the projects that I had the good fortune to get involved in towards its closing, but still involved in all the same, was building this non-government organization called Invest in Knowledge Initiative, or IKI, in Malawi. And this came out of a decade-long project led by the University of Pennsylvania, where they were following people over 5-10 years and asking them questions about their behaviors, their relationships, and economic status, and so on, migration patterns, to think about HIV risk and vulnerability, right? It was an HIV study. That's what they're funded to do. And after their first wave or two, they would come back every other year to survey folks. After their first wave or two, they thought, well, wouldn't it be great if we could hire the same people that we trained, spent a whole bunch of time and money training the first time to keep doing some of this work, right? What if they could actually learn to do research and support themselves to doing research when we're not here, in the year we're not here? What if they could actually ultimately fund themselves, not just through our project, but through other development-related health surveys, right? The World Bank runs several of these every year in Malawi. And so they start this NGO, initially with a lot of hand-holding, right? And try to get them fundable, try to get them out of the red, right? So they're actually bringing in money. And economic security is a big problem in Malawi. There's a lot of basically what you might call the gig economy here, but people living like one job to another job and not having a stable source of income, right? They lack a lot of formal employment. So this was a solution to a lot of problems, actually. By building this organization, people could spread funds out over the entire year, right? So they wouldn't just get money when in the academic summer when people had a lot of research projects, but they could spread that out so that in February there would still be a paycheck, right? And so this organization has been very successful in the last 10 years in terms of attracting new research opportunities, doing other studies, so much so that there's even like momentum to create a second organization in the other, like in another province, right, where there's more opportunities for research, more opportunities to train people, more opportunities to get people stable work, right, and ultimately train them in various aspects of data collection, data cleaning, all of that kind of stuff, and get them actually working on the project, developing their own projects, right? So there's a clip on some of these guys linked down at the bottom. I think that's about my time, and I'm happy to wrap up, but I'm also sticking around. So I'd love to hear your questions, talk a little bit more about what you are looking to do in global health, or how you like came to be interested in this talk today. And I'm going to an ice cream social after this too. If you have to run or don't have your question exactly formulated right now, feel free to email me. You can tweet at me, whatever. Float your boat. So all of that's up there, but that's what I have for you today. Thank you.
Thank you very much. We do have time for questions, so please, anyone, questions or comments?
Yeah, you kept talking about critical thinking and how to apply that and make sure we know that both are direct and indirect actions and what their consequences are. So you talked about one towards the last half of talking about trying to train those people who are more suitable for this scenario, not just because maybe you can't do it, but maybe it'd be better to have someone to represent. Mm-hmm. But what are some questions, because I'm a business administration major, and I'm not really, I like health and I really want to go into that, but I might not be a person who's directly going into researching for this.
Sure.
But I'd wonder, I know that globalization is very important, integrating is very important, so what are some questions that we should ask ourselves whenever we're dealing with a new group or a different group and trying to integrate what they get and what we get without trying to push our ideals or ignore theirs and stuff like that?
Sure. The question, in case you didn't hear it, is about what kinds of questions you can ask yourself or ask others when you're trying to engage in this work, even if it's not necessarily health related, since he's a business major. I kind of catch that more or less there. And you had some other detail. But I think that's a good question, because I think this applies outside of health too, right? So I had some questions there, like, am I the best person for this job? Is there somebody else that could do this, that I could train to do this, that would be useful to have their input on, and so on? I think those kinds of questions would also carry over to business, and you could also think about, just what is, like in business, what is this other, like, let's say startup or community group that I want to work with, or, other things businessy. Sorry, not a business person. What do they want? What do they actually want? Listen. That would be my advice. Listen to them, ask them. What do you want? How can I help make that a reality? Does this thing that I actually want mean the same thing to you? Does it overlap with what you want? Is that even an important thing to you, or should we talk about something else, right? I think we too often come to the stage thinking we have the monopoly on good ideas, but we definitely don't have the monopoly on good ideas, right? Other people have good ideas. They live in whatever context you're visiting or trying to work in, and know some of that. They have those relationships. They have ideas about what works, what doesn't, and they may even know what came before you, right? And have specific meanings or interpretations attached to some of that work that's already been done, right? I have a friend who works in technology and education in South Africa, right? And so there are certain kinds of challenges that come not from actually bringing the technology physically to a school, but in getting people to use it in the way that it's intended, right? Obviously, people use technology in lots of unintended ways to good cause, but to actually get teachers to pay attention to it and look at it and think about it as a resource and not a hindrance to the work that they need to be doing on a regular basis, right? Is that useful?
Other questions?
So thinking culturally, global, coming from, kind of a rural community, just thinking like Murfreesboro, we're very, very isolated from any sort of like global health. So taking a subject like global health and other topics with kind of like international significance that aren't really affected, or like rural areas like this aren't really affected by those, how do you find like are the best ways to spread awareness for that and also garner support in areas that aren't really affected by this sort of topic?
Well, I wonder what you mean a little. I'll push you a little bit on what you mean by you're not affected by them. No, it's okay. I'll get, sorry. So just because, like, Murfreesboro is on the globe, right? Sure. So it's like, it's a place that is useful for talking about in terms of global health, right? Too often we think about this as other places, right? Not here, but somewhere else. But I would encourage you also to think, like, my place, like in rural Tennessee, or if you're from Mississippi or Georgia or somewhere else, is on the globe. It has issues that are actually similar to other places elsewhere, right? And those may not be neglected tropical diseases, because we're not in a tropical climate, which global health does focus a lot on, tropical kinds of diseases. But we also focus on STDs, right? We focus, which certainly I would imagine there are things like gonorrhea going around, right? I won't hazard a guess at how much, but I imagine it's out there, right? And affecting certain people more than others. There may also be similarities in terms of what global health is trying to do around substance use. And mental health is another priority in global health these days. And so these are all things that I think we can look around the world to think about how other places and communities have dealt with some of these issues, to think about how we might also respond. That might be similarly, we can take something that feels similar and feels meaningful and culturally relevant to us around, let's say, substance use that's been going on in Russia, for example, for a long, long time, and think about those kinds of issues. But we could also say, you know, this is a very particular space. It has its own social issues that are related to mental health that we want to address differently, right? But like, we've been talking a lot about student mental health, a lot in just in our US context, right? Why is that not a thing other places? Certainly that's probably a thing other places. If it's not, maybe we should be looking around in other places about what they've been doing to actually kind of address some of those issues. So I would kind of challenge you to think about your place, Murfreesboro or wherever that might be, as a place that's on the globe, as a place that can learn from and think about what other people are working on, and not necessarily like global health being a thing you have to go somewhere else to, right? That you can do it here. We have a lot of inequalities here in the US that need some of that attention too, right?
So I had a question about the education surrounding abortion practices and also the health risks that are involved. You know, the statistics on that, just about the American society. What would you say is the best platform to address, you know, the medical side of what the actual procedures are, and even mental afterward health effects regarding abortion? What would you say is the best platform to educate the American society, just on everything that's involving that?
Nice controversial question. I'll throw it right in there. So I teach a class on U.S. politics of health, and so I teach a couple weeks on abortion politics in the U.S. in a comparative kind of context. So one of the things that happened in the U.S. that's really interesting, there's a book that I teach, it's called Doctors and Demonstrators, which might be right up your alley if you're really interested in this question. And it's thinking about what happened in the 50s and 60s in the U.S., particularly around claiming abortion as a medical issue that didn't happen other places, right? So in the author is comparing to the US or to the UK and to Canada, which pretty seamlessly, quickly, and without a lot of controversy, legalized abortion, but with certain constraints, right? In terms of, you know, you have to have a hospital signatory, you might have to have another few doctors sign off. This is in the 60s, right? But that's because doctors kind of claim this as their issue. In the US, doctors don't do that. They make different choices. They don't have time to be doing that. And so they're requested to file an amicus brief in Roe v. Wade, and they decline. So they don't actually participate in this at all. And so abortion never gets framed as a medical issue in the US like it does in other places that are considering the issue at the same time. And so different conversations emerge, right? When we start talking about the outcome of the Supreme Court case, we start talking about abortion as a right, as something that's elective. Well, when something's elective, the government decides not to pay for it, right? It's like breast implants or nose surgery, right? It's elective, you pay for it. And so it's not funded like it is in other countries that decided it was a medical issue. It's not as widespread as it is in countries that decided it was a medical issue. And so that framing around rights has also had particular implications for the counter movement, right? In terms of what arguments get mobilized against abortion in the US. And so this is a really important and I think critical, interesting history, like fascinating history, that I think a lot of us maybe aren't aware of and maybe should be thinking more of. And so to the extent, I would say in the US, the doctors get involved, maybe we can shift some of that language if your intent is, of course, to promote access and that kind of thing. I won't take a political soapbox here, but so if that is your like perspective, then engaging medical opinion might be one of those things that can help do that. In the global kind of context, we've actually seen a lot of that rights language be somewhat successful, but I think it is running into some kind of challenges these days, again, because it's not been claimed as a medical issue.
Something that I wanted to say about your talk that I appreciated is that you addressed the idea that a lot of biases actually have real consequences, and that's something that people pick up from their peers and not necessarily from scientific data. And that's like an issue that really bothers me every single day. And I'm sorry to also be controversial, but with the issue about vaccines and causing autism, it's been disproven like a million times. Yeah. But people still believe that, and that still really has consequences. And so I really liked that you mentioned that in your talk. Thank you.
Yeah, I think that's another critical issue, which I teach less on just because it's very much in the popular kind of imagination, and people, I think students often feel fairly educated about some of these issues. But I mean, one thing to be thinking about is these ongoing kind of measles outbreaks. We certainly had some seems like opportunism in terms of messaging and so on in the most recent Michigan case of outbreaks and so on. So I think it is something to be concerned about in terms of thinking about where people get their information, how they're actually thinking about these issues and the biases they bring to the table, right? And I think policy is also changing, right? So California in the last couple of years has said we're not going to allow anybody to have an exemption that's not a medical one, right? And this has actually already changed vaccination levels in just the last couple of years. And they're not kids aren't allowed to go to school if you're not vaccinated, right? And so it's kind of changing in the policy on those issues, but also kind of pushing some of our ethical debate on what the state can require and in relation to health, and how we go about doing that in a way that's informative and doesn't feel coercive and doesn't exclude people that maybe also need access to education, for example, right? Yeah. Great question so far, you guys.
So from the perspective of someone a researcher or someone involved in drug development, a portion of your talk that really stuck out to me was the fact that the United States is only working on this one serotype of the HIV/AIDS, and just collecting samples in your area. From a research perspective, what would your advice be to someone in that setting to kind of combat that? Because in addition to that, where there was such a large gap between getting vaccines to people in other countries, that's more of a geopolitical issue, not necessarily related to research, but I think maybe the intent of researchers was to get it over there, and then they're not involved in that process. So I guess just what's your opinion or thoughts on that?
Yeah, I think that's a difficult question, right? Because we're thinking about what makes the research actually work, right? Which is let's all work on similar strains and or even the same ones so that we can actually compare our results, right? That's kind of a thing in research. We want to make sure that thing is working. But we all have the same sample, and these same samples came from just a few people, right, in like 1985, the likelihood that they even, like because of all these mutations, even reflect what might be useful in a US population by now is actually smaller than it was, in 1985, right, because of these changes and mutations and recombinations and so on. So it's even less useful, like marginally less, but less useful for us as well in terms of what's going on. But I think that's a good question. It's one of those things that it's hard to change because it's kind of integrated so well into that research like ethos. But being knowledgeable about it, I think, is a good first step. So that's starting to happen. So we actually don't know if the drugs developed for subtype B work as well, better, or worse on subtype C or A or D, right? So doing some of that research to actually know, like, is this a problem, is, I think, step one, right? Something that we should be paying attention to. And so people are starting to do that research to see if these other subtypes behave differently, right, in terms of the things that we've developed. And paying attention to those kinds of distribution-y questions, I think, is important as well when we think about what's going to happen on the back end, right? If we have developed drugs, and regardless of how well they perform with these other subtypes, we've actually kept them from people who need them for 10 years anyway, right? And so we already did a lot of damage that way. And so not giving them because we think there might be something in terms of how they would behave with that subtype would seem, again, unethical, right? And so kind of working with what you have and revisiting those questions often when new information arises would be the thing that I would maybe suggest there. Yeah.
All right, we will conclude with that question. Thank you so much.